Hello and welcome. We're so glad to see you all with us today. We're going to get started in just a moment to allow a few more folks to join us. I see we have some folks saying hello in the chat. If you'd like to introduce yourselves, we'd love to know who you are and where you're coming from. So feel free to utilize the chat for that, and we'll get started in just a moment. Thank you so much, Tina, and I'm sure folks will be coming into the chat. For the sake of time, we will get started. So officially again, hello and welcome to this webinar on improving health outcomes through preventive services for older Asian Americans. This webinar is in partnership with the Association of Asian Pacific Community Health Organizations and the National Center for Equitable Care for Elders. My name is Ariel, and I am the program manager of NCECE. To provide a visual self-description, I am a white woman in my mid-30s. I use she, her pronouns. I have long golden brown hair, and I'm wearing a purple sweater. So many folks are familiar with Zoom, but since we're in a webinar format today, just want to remind folks that all of your cameras and audios are turned off, but we would love your participation in the chat box, in the Q&A. And so we just want to remind you of the keyboard shortcuts for each function, as well as the option to turn on closed captions. If you have any other access needs today, please message Kara in the chat. For my own access needs today, I'll be reading from a script. So the slides will be shared in the chat for those who do better with following along. And we will also release a transcript with the recording of this session within the next week. The Association of Asian Pacific Community Health Organizations, or APCHO, was formed to create a national voice to advocate for the unique and diverse health needs of Asian American, Native Hawaiian, and Pacific Islander communities through advocacy, collaboration, and leadership. APCHO's focus areas are health equity and access, training and capacity building, and healthcare quality and innovation. To learn more about APCHO, you can visit their website, follow them on social media, or learn more about their trainings by subscribing to their SoundCloud. And about the National Center for Equitable Care for Elders, our goals are to advance healthcare providers' knowledge and disseminate promising practices by providing healthcare and supportive services to older adults, to increase the amount and accessibility of healthcare services provided to older patients at health centers, and to improve health centers' responsiveness to enhance the quality of population-based and outcomes-oriented healthcare programs for community dwelling older adults. We'd love to stay connected after this session, so feel free to check out our website and social media platforms to learn more. So when you signed up for this webinar, you likely saw the learning objectives, but just wanted to remind folks that at the end of this hour, we are hoping you'll be able to walk away being able to describe factors that contribute to older Asian Americans experiencing lower rates of service utilization for physical or mental health conditions, to explain the relationship between mental health and chronic conditions among Asian American elders, and to develop culturally responsive strategies for increasing patient trust and providing appropriate community referrals. We have a wonderful panel discussion today, but first we're going to do a little bit of level setting. So as most of us know, the United States is aging at a rapid pace, with a population of older adults set to outnumber that of children within the next few years. Among these adults 65 years and older, Asian Americans are the fastest growing racial subgroup, which is projected to increase from about 4.6% of that population to over 8% by 2060. This context underscores the importance of health centers and community-based organizations, excuse me, to ensure they're prepared to offer programs and services that are inclusive and culturally responsive to these populations. When examining any kind of health disparities in Asian American elders, it's important to consider an intersectionality framework. So we are all aging, but we don't all age in the same way. In addition to being impacted by ageism or ableism, older adults may experience compounded disadvantages to healthy aging based on the intersection of their age with other aspects of their identity, including gender, race, ethnicity, sexual orientation, and more. Despite being the fastest growing racial group, including over 50 ethnic identities with over 100 languages spoken, Asian American, Native Hawaiian, and Pacific Islanders still experience aggregation into this singular monolith. Um, when it comes to looking at health data. So this aggregation erases the unique and diverse needs and experiences of smaller racial and ethnic subgroups. Racist assumptions about Asian Americans stemming from the model minority myth invalidate and trivialize the nuanced lived experiences of individuals in the Asian diaspora, including South, Southeast, Central, Western, and East Asian populations, which prevents the ability to identify and address existing health disparities. While there's some data that might suggest that older Asian Americans have lower recorded rates of mental health issues compared to other racial groups, we also know that many elders may be hesitant to report concerns to their providers because of religion, stigma, or lack of culturally responsive care options. So as Asian Americans age, the cultural and language barriers they experience can increase social isolation as well as subjective feelings of loneliness. Challenges in acculturation may decrease their reported levels of life satisfaction, particularly if there is inadequate support from family or other caregivers. So some key considerations here: cultural values, family dynamics, spirituality, all play pivotal roles in shaping health decisions and perceptions of illness among many Asian American communities. Improving cultural agility while engaging these patients may involve looking beyond a Western perspective of healthcare. For example, increasing awareness that certain health topics may carry stigma or taboos, the need to acknowledge and integrate traditional healing practices such as herbal medicine or acupuncture to provide holistic options that align with the patient's beliefs. Further, many Asian American communities place a strong emphasis on familial relationships, so including family members in medical discussions and decisions can help patients to feel supported and respected. Essential factors in the physical and mental health of this population often include social connection, community support, as well as individual and family levels of acculturation. As healthcare providers strive to incorporate culturally responsive care approaches into their practices, it's equally important to have access to reliable resources and support networks. Resources might include in language educational materials in print, visual, audio formats, partnerships with trusted leaders, and culturally specific programs and organizations can significantly increase the effectiveness of outreach programming, translation efforts, and reducing levels of that social isolation. So while originally written for a more Western audience, you'll see on this slide, there have been some successful adaptations of evidence-based programs, such as the program to encourage active, rewarding lives, also known as PEARLS, that provide culturally appropriate mental health support. And lastly, on this slide, many Asian Americans bear a complex historical legacy that has significantly shaped their relationship with healthcare systems. The experience of colonization, exploitation, and displacement has left deep scars that continue to influence the perspectives and challenges Asian American communities face, including their interactions with institutions like healthcare systems. These historical traumas and the subsequent mistrust have far-reaching implications for addressing those unique healthcare needs of this population. In order to see meaningful change in health outcomes for older Asian Americans, we must understand not only an individual patient's needs, but the context of their culture and communities. So we'll dive into this a little more deeply when we have a panel discussion later in this hour, but we did want to briefly acknowledge how the COVID-19 pandemic in many cases worsened the existing health disparities experienced by Asian American elders, both physically and mentally. Despite being largely unreported, rates of racism, violence, anti-Asian hate crimes towards these elders increased up to 77% during the height of the pandemic. This environment led many patients and even clinicians to fear seeking and providing healthcare. It is also important to acknowledge the other forms of violence that have impacted Asian Americans, including anti-Muslim sentiments and ongoing discrimination of Central and South Asian populations, the disproportionate impact of gender-based violence, human trafficking, and exploitation among Southeast Asian immigrants, and the dispossession of land, rights, and cultural identity, as well as the need to contend with social and political events in homelands and in communities across the global diaspora. Partnerships with culturally specific agencies and programs that understand the cultural nuances, linguistic barriers, and social stigmas that can impact elder Asian Americans' access to resources are critical for fostering trust, rapport, and relationships between Asian American elders and their healthcare providers. And our panelists today are going to be able to give really fantastic examples of that. So I'm going to briefly mention who we're going to be hearing from today. We have health center representation on both coasts of the continental United States today. Our first panelist is going to be Dr. Huang Lei, who is the Chief Dental Officer of Asian Health Services located in Oakland, California. And after that presentation, we'll hear from the Lowell Community Health Center and the Meta Health Center in Lowell, Massachusetts. And from there, we have Dr. Noreen Paul and Sarah Bradshaw joining us. So after these spotlight on their programs, we'll have a wonderful discussion with our experts pictured here, more on this topic. So I will let Dr. Lei take it away.
Okay, well, thank you. Welcome to our webinar. Yes, so as Ariel said, I am Hoon Lei. I am the Chief Dental Officer of Asian Health Services. So before I begin my lecture, what I'd like to do is just talk a little bit about Asian Health Services, who we are and who we serve. Next slide, please. So Asian Health Services was founded in 1974. So next year we'll be celebrating our 50th anniversary. It was founded as a one-room clinic with all volunteer staff, mostly the students from UC Berkeley Public Health Department. We are known for our advocacy efforts. And I'm not going to read everything that you see here because you'll be receiving the PowerPoint. Dental program did not start until 2003, and we were the second dental clinic in the state to have electronic health record. We were the first health center to host an AHED, which is an advanced education in general dentistry residency program in California. And then later on, as the community needs became so huge that we continue to expand. In 2016, we launched a $3 million campaign to create California's first dental clinic with integrated behavioral health services and 4 specialties. We actually hired a licensed clinical social worker to work in that dental clinic. So we are the first in the country actually to do that. 2022, we launched our very first mobile dental program. And that's what pandemic taught us. We became very innovative with telehealth and also a remote preventive dental program. Next slide, please. So at this point in time, the dental program has 3 clinic sites, 2 school-based sites. One is located in the high school with integrated care model, medical, dental, and behavioral health. We have 2 mobile vans and we are planning to establish a new dental site in South County. We also apply and are rewarded for teaching health center. So we'll be establishing our own advanced education in general dentistry residency program, hopefully by 2025. The previous program was actually affiliated with another program. And we are also working to establish our PACE center in the near future. Next slide, please. Okay, so for all of our adult patients that come into dental clinic, we we focus on preventive, of course. That's just our mission. But we are also focusing on educating our patients in this very robust integrated care model. All of our patients have their blood pressure taken at every visit. And if the blood pressure is high, then what we do is that we follow a protocol, on it. We confirm with patients for their medical history, confirm medication compliance. We educate our patients on medication compliance. And this is really important because we have found out that a lot of our patients, especially geriatric patients, are not really following what their PCP recommends. Some would just stop the medications just because they feel like they're doing okay. We do PMI intake in dental, which is something that most dental clinics do not do. And we were the first in the country to screen depression of our patients. We use the same patient health questionnaire 9 that medical department uses. We started our depression screening way back in 2015. We do have a very good referral system if the survey is positive. In 2019, we started our diabetes screening. So our patients actually fill out the diabetes survey. And if there is a positive survey, then we offer hemoglobin A1C testing right in the dental clinic. If the number is high, then we refer to our PCP, for further evaluation. And if it's within the pre-diabetic range, then what we do is that we refer the patients to nutritionists. Medication compliance, I already stated earlier that it is, we have a very good protocol to confirm and remind our patients on medication instructions regarding regimen and frequency and compliance. Next slide, please. The reason that we focus a lot of our training and education on geriatric patients is because of the fact that we have a very high geriatric patient population at Asian Health Services. Nationwide, the average geriatric patient population at a community health center is about anywhere from 9 to 11%. We have 30 to 32% geriatric patients in our dental clinics, and we have 55% female, 45 male. About 15% of our geriatric patients are completely edentulous, which means they are missing all of the teeth. About 35% are partially edentulous. About 75% of our patients have gum disease. When compared to the general patient population, about 32% have gum disease. But when it comes to geriatric, as you can see that, it's a much higher percentage. And this is something that we educate our patients on as well, that the mouth is really the mirror of health and disease. And elderly patients have more complicated dental needs because they do have more complicated medical conditions. Next slide, please. And why is oral health education important? There is a medical dental relationship, and it's not important only to the patients, but also to the caregivers. And this is the reason why our providers here at Asian Health Services, focus on the education, and of course the treatment services for our patients. A lot of our patients, as you know, like Asian patients, have a very high percentage of hepatitis C. That could result in bleeding problem, when we treat our patients. Osteoporosis, medications that can complicate oral surgery and implants. They also have no-Sjögren's syndrome, which is the dry mouth, from that. Hypertension, a a lot of hypertension medications can also result in swelling of the lips, the gums, dry mouth, loss of taste, and also they could have some oral lesions in the mouth, including like gingival overgrowth, like the gums are swollen or thickening of the gums. Diabetes, they usually have chronic and advanced periodontal conditions due to diabetes-induced inflammatory response, bacterial or fungal infections, and of course also medications. Mental health depression also leads to oral health neglect, and the dry mouth for medications can also lead to cavities and of course gum disease, ill-fitting prosthesis. So a lot of patients complain that the dentures don't fit because they don't have enough saliva in the mouth. Next slide, please. So the medical dental relationship continues with the cancer. Oral cancer is one of the leading dental cancer in Asian patient population, and it's probably contributed from these from smoking. There's a very high prevalence of smoking, especially among the male Asian patients. Organ failure and transplant. These patients have very severe gum disease, and they do need to have clearance before transplant can be, performed. So we see a lot of these patients with bone loss, with gingivitis, and also, with dry mouth. Malnutrition, we have seen a lot of our geriatric patients because of the missing teeth, because of the gum disease, because of the ill-fitting dentures. They end up with sores in their mouth, inflammation, and they can't eat very well. Dry mouth, same thing I stated earlier. This is a very common condition in our elderly patients due to the medications that they're on. Osteoporosis, I already spoke earlier. A lot of these patients, we have to take very great care when it comes to oral surgery because they can develop a very serious osteonecrosis, which means the bone just does not heal up correctly. Next slide, please. So when it comes to geriatric care, we have done a lot of outreach, for our patients. Besides the education that we do, on site, we also have to provide screening to 4 senior housing projects. We go there, we do the screening. We also provide patient education using PowerPoint, cancer self-screening lectures to the patients. We give the patients the toothbrush kits, and also we refer the patient to the clinic for urgent care. And it's important, to remember that we can't just educate the patients. We have to educate the caregivers, the family members, and even the staff at these senior housing projects. We also implemented a program, for sodium, like sodium diamide fluoride, for caries. And of course, I talked about the depression screening and the diabetic screening. Next slide, please. So this is very important when you see geriatric patients. We need to educate them on cancer self-screening. A lot of them do not know that if they have a swelling or any sores in their mouth that lasted for a long time, it's potentially oral cancer. So I think we really need to focus on that to educate our patients. So next slide, please. So the next thing that I want to say is that at Asian Health Services, we do more than just dentistry. We have a very great specialty mental health department. So during pandemic, we actually encourage and talk to our patients about all of these activities that are going on, at Asian Health Services, self-care, and also community outreach activities. So I'm going to end there. Because I do think that, our next speaker has a lot to share, with all of you. So thank you very much for your attention. Next slide.
Hi, everyone. My name's Sarah Bradshaw. I'm a nurse practitioner and primary care provider at the Meta Health Center within the Lowell Community Health Center in Lowell, Massachusetts. The Lowell Community Health Center was founded in the 70s in a big wave of community health center openings. The population of Lowell is just over 100,000 people, and about a fourth of that is AAPI residents. And almost 30% of the population of Lowell is immigrants and refugees. And at the Meta Health Center, we primarily see immigrants and refugees, new arrivals to the US. 50% of the residents of Lowell access services at the Community Health Center. Next slide. So that's the larger health center, the Lowell Community Health Center. Naren and I, who will be presenting today, work within the Meta Health Center, which was founded in 2000 to serve the Southeast Asian refugee population, specifically torture survivors, Cambodian refugees. So our health center includes primary care, mental health care, so a behavioral health arm, acupuncture, massage, dental care. We also have an eye center, and then dedicated community health workers who work with just the Meta Health Center patients. We currently serve about 4,500 patients. The majority are Khmer speaking, Cambodian, and about 20% of those patients have diabetes. So that's a big focus in our practice. Next slide. As Ariel mentioned earlier, the diabetes burden in Asian Americans is quite high. A 2016 study found that Cambodian refugees had more than twice the rate of diabetes relative to the US population. Data in Massachusetts, where we have a large population of Cambodian Americans, found that Cambodians die from diabetes at 6 times the rate of the general population. So it's a very concerning source of mortality and morbidity. And we see really high rates of complications of diabetes, such as end-stage renal disease, in our Cambodian patients. Next slide. So all of this is to say that diabetes screening is extremely important. We want to catch diabetes while it's still in the pre-diabetic range, or before a patient's blood sugars get out of control and they're experiencing many of those complications. So Asian Americans tend to develop diabetes at lower body masses than the general population. There is a big push to screen Asian Americans at a BMI of 23 rather than 25, because we know that obesity is not as prevalent a risk factor for Asian Americans developing diabetes as it is for white Americans or other groups within the US. So age actually may be a more salient risk factor for diabetes development than BMI or body weight in Asian American populations. So as we see our Asian American populations age, we need to be really careful about screening for diabetes and really cognizant of this risk factor. Next slide. So to this point, we have done quite a few big projects in Meta to make sure that we are screening all of our Asian American patients, especially our older Asian American patients, for diabetes. So about 2 years ago, we reached out to 94 patients who had never been screened for diabetes. The majority of our patients were screened for diabetes within their primary care relationship, but we determined who had not been. 36 patients were over the age of 45, 59 patients were 21 to 44. And then we outreached to all of these patients. We were only able to screen about 37% of the patients we outreached to. We think that's probably related to the fact that we were doing this during the COVID-19 pandemic. So it'll be something that we need to revisit, but the data from this was really interesting. Next slide. So of the patients over the age of 45 who were screened, 25% of them had previously unrecognized diabetes or prediabetes. So that's a huge number or a huge percentage who had diabetes that we had not previously recognized and we were not managing. So they were at high risk of complications from diabetes. All of the patients with diabetes or prediabetes were BMI 23 to 24.9, and they were all over the age of 45. So as I mentioned before, age seems to be a much more salient risk factor for diabetes development than BMI in Asian American populations. Next slide. So because of all of this, the Health Center has really put a focus on enhancing our diabetes care for Asian Americans. And so my colleague, Naren Paul, one of our clinical pharmacists, is going to talk about her program and how that has supported diabetes management within our department.
Thank you, Sarah. So my name is Naren Paul. I am one of the clinical pharmacists. There are 5 of us on the team here at the Lowell Community Health Center. I specifically serve patients in the Meta Health Center. And our program is fairly new. It started in the fall of 2021, which is when I joined the team. And we have made a lot of adjustments to our referral program so that it's much easier now in Epic. We just switched over to Epic. So the program is very well developed now. However, there are still the same criteria that we used when we first started the program. So for providers like Sarah and everyone else on the team, if they screen a patient who comes out to be to have diabetes, they are referred to us, which if they meet any of these criteria here, we'll enroll them automatically into the program. So usually we see patients with A1Cs that are very high, greater than 9%. If they have any issues with hypoglycemia or hyperglycemia, so like very huge swings in their blood sugars, we'll see them as well. We also do trainings on new medication teaches for insulin, for GLP-1s, or for glucometers. And we also assess patients for CGM therapy, which is the continuous glucose monitoring, which was a program that was also started when our clinical pharmacy team started in 2021. Next slide, please. So this is the referral workflow. Once a patient is identified by the primary care provider, they send an encounter, they open a referral, and they send the encounter over to the clinical pharmacy team. One of the clinical pharmacy technicians will screen the referral, and if they meet any of those aforementioned criteria, they are automatically enrolled into Compass Rose, which is our program that tracks our patients for clinical pharmacy management. If for any reason the tech sees that they don't meet any of the criteria, they will send the information over to the responsible pharmacist in that department. So to me, if it's a Meta patient, and we look at each case by case to determine, okay, you know, we should enroll this patient, or maybe just set up a one-time kind of education just to go over what barriers the patient has. And if then, you know, we see that they need to be followed even further, we'll enroll them into the program for ongoing follow-up. Once the patient is enrolled in clinical pharmacy program, the technician reaches out to the patient, they schedule an initial appointment with myself, or if I'm not available, if it's an urgent matter, we schedule it with the next available pharmacist on the team. Next slide, please. So during my initial visit, the biggest thing that I want to establish first is that trust and rapport with my patients. So that is the crux of my visit. I try to meet all the other 4 topics when I'm in the appointment with them. Sometimes we don't get to all of it because sometimes once they see me, all of it comes out, and whether it's medication adherence, or whether it's, you know, they're in need of another referral to see someone else, another care team member. it all comes out during this first appointment. And in order for me to get it out of them, I try to build this trust and rapport right off the bat. And the way I do that is for the benefit of the appointment, I always greet the patient in Khmer first, if they're a Cambodian patient, which a majority of our patients are. So I always do the traditional, Jimbit Sur, and I speak to them in a very formal way with respect to the elders in the community. I don't speak them in Khmer the same way that I speak to my friends in Khmer. So that's just showing them respect for the culture, respect for the individual right off the bat. And that's how I usually kind of reel them in and get them to trust me and get them to open up and tell me what their issues are. So the bulk of the appointment really is about medication management and building better habits to improve their diabetes management. And to do that, I have to assess the barriers that are the patient is experiencing. And also, if I feel that I'm not equipped to help them in all of the barriers that they're experiencing, I send them off to other care team members like a registered dietitian or our SDOH team to address their concerns as well. So that's when I refer them to other team members. Next slide, please. So the breaking through the barriers is the biggest thing. So it's definitely, because I speak the language, the patients are already, ready to talk to me, ready to listen to what I have to say. They're ready to report, what issues they're experiencing. I can empathize with the patient because I too am a type 2 diabetic. I have been for almost 2 decades now. So when I tell them that, their eyes light up and they're like, oh, so you understand. So that's how I like to start off my my first appointment with them. So we kind of connect on that level. And I always listen to them, and active listening. So I listen and I let them speak, and I ask them open-ended questions to see where they're at with their diabetes management. And I always ask them for permission to start medication, or how they feel about this medication, or how they feel about this lifestyle change before I go ahead and put it in our plan. And as I said, the appropriate referrals also help. Sometimes patients are afraid to speak up about their mental health issues or their SDOH concerns. So they don't really tell their PCP these things. And sometimes it's a time issue. The PCPs, Sarah will sometimes only have 20 minutes with a patient, whereas I have a whole hour. And they can tell me everything, and I just document it, and I ask them permission if I can share this with their primary care provider. And if they say yes, then I'll share it, and I'll bring it up, and I'll refer them to the correct team members. I also help guide them to figure out which, what they can do out in the community to help them with their lifestyle changes, whether it's YMCA memberships or, anything like community servings, which is a food program that can provide meals for them. So I try to guide them down the right path to help manage their diabetes in that way as well. Next slide, please. And our take-home message here is the word metta, which means positive energy and kindness toward others. So when patients come here to the Metta Health Center, they're already welcomed with open arms, because our whole health center in Metta embodies the kindness and positive energy that we try to project to our patients, so that they can feel welcomed and that their problems are understood, and we're working to support them and help them in any way. And to finish it off, I just would like to share Mark Twain's quote that kindness is a language the blind can see and the deaf can hear. So even if you don't speak the language, even if I didn't speak Khmer, I would find a way to connect with all of the patients in some type of way. We have Afghanistan refugees. So, I learned their cultures and I learned their ways, and I try to respect each individual person according to their culture. So that's what I have to share from my experience here in the Metta Health Center as a clinical pharmacist.
Wonderful. I see we had lots of hearts coming through, and we just thank our panelists so much for sharing their insights and looking a little deeper into your programming. We do intentionally have some time held for some questions that we developed in advance, but if folks in the audience have been reflecting on, questions or things they want to learn more about from either of the health centers, please do use the chat box, the Q&A feature. We'll make sure that those get asked as well. But when you receive the slides, you'll see that we have the prompts on them, but we'll have Noreen and Sarah come on camera if that works for all of you. And we'll go over these prepared questions and kind of see what else comes in. And I know that both of your presentations have kind of touched on some elements of these questions, but it'll be great to circle back to some of these points, especially in keeping with the overall theme of the session. So I think we'll go back to a slide that we had in the beginning in level setting around the pandemic. And in both health centers and your experiences, how have the challenges of the last several years impacted rates of depression and chronic conditions in this patient population specifically? So we'll have Dr. Lay go first and then the little folks, if that works. Oh, I think you're still muted, Dr. Lay.
Sorry. So
No
as
worries.
I stated in my presentation, that Asian Health Services was the first to do the depression screening way back in 2015. And then we started the diabetes screening with hemoglobin A1C testing in 2019. That being said, I think pandemic created such another level of stress, among our patients. It created fear, isolation from the society, and I think it had a much more serious impact on the elderly. And I do believe that the impact became probably worse for the immigrants, especially, who are so used to, like living in a multi-generational, living in arrangement. But then during COVID, I think that they probably got separated, from the family members for fear that, the elderly, if they do get COVID, I mean, there could be, adverse, very serious, adverse consequences. So I think that really created that isolation, which of course impacted the mental health condition on these patients. And then another thing that we witnessed with geriatric patient population is the digital divide. When we started telehealth, yeah, it's all great. We can stay connected with our patients, but many of them do not know how to use the smartphones. They don't know how to use Zoom, Doximity, so that really created, a lot of challenges. At Asian Health Services, our staff was so wonderful, during this whole pandemic. And that is, we actually hosted sessions to really show our community members how to use these smartphones, how to use, these platforms, so that it's not only that they got connected with us, but also they were able to contact, for medical advice. So I think, and that definitely has also helped when we started our remote medical monitoring process, when the patient actually received the blood pressure cuffs at home, and with a smartphone, so that, the data could come into, Asian Health Service PCP. Same with dental. We started the remote, fluoride varnish program. We send the fluoride home to the parents, and then we connected with them, through Zoom or Doximity, and really show them on our hygiene. So overall, I think the challenges were there, but again, I think that in healthcare we pivoted, so quickly. But yeah, definitely, it had a lot of impact. Patients were not getting medication. They forgot about the medication compliance. So we see all of that. But
I'm sure. I'm
yeah.
sure. Thank you for that. For the low folks, how does that resonate with you? Were there other things that you noticed in your patients, the impact of the last few years on their health?
Yeah, so certainly to build off of what Dr. Lay said, when the pandemic started, like many community health centers and primary care settings, we moved towards telehealth. And although that was a great thing in many ways, we saw less of an engagement in care with our patients who were older and who were non-English speaking. And so our older Asian American patients, certainly fell in that area. Our older Asian American patients with diabetes, we saw many who didn't have care or who didn't have the frequency of care that they would have had our office been open and they were able to access care in the way that was familiar to them. And so we certainly did see patients whose diabetes got out of control during that time, just because of a lack of engagement and care. I think we saw the same thing with depression. We saw patients who had previously been diagnosed with depression. We have a large PTSD population. And, you know, we saw that they weren't able to engage in a way that was familiar with them, and that caused some disruptions in their care and worsening of their chronic conditions.
Thank you all for sharing on that. I do see that we have a question in the Q&A. We'll wait for a few minutes if there's others, and then we'll go through audience questions. Just want to acknowledge that I see that question there. Would love, I know, Naren, that you had talked about this right at the end of your presentation around how you're building rapport, and I love the individual engagement that you have with those patients. I'm wondering, from the Lowell folks first this time, are there any other approaches that you found really successful in engaging with Asian American elders in building that trust and rapport? Obviously, number one is always going to be that you have the time, you have the face-to-face conversation. Is there anything else you can think of that you'd like to share in this area?
Yeah, I can definitely answer that. So I think just having the language and the visuals of their culture, of everyone, not just Cambodians, but like everyone who walks into our health center will feel welcome. All our signs are in multiple languages. We have decorations and artifacts from different countries displayed. So it's not a sterile, you walk in, it's just medical facility. So patients feel welcome that way as well. And then the flip side is we also are out in the community a lot too. We're at the Cambodian Water Festival, the Southeast Asian Water Festival. We're always out there, and we have a staff that's very diverse. We have staff that speak multiple languages, and a patient can always find someone who looks like them, who speaks their language, so that they feel comfortable.
That's wonderful. Thank you so much. Dr. Lay, is there anything that you'd like to share here around approaches to building that trust and rapport with your patients?
Besides the workshops, that we hosted, our staff hosted, to show the patients on how to use their smartphones and the different platforms for virtual meetings. We also hosted like mass vaccination events for our patients. At the first mass vaccination event that we did, we vaccinated over 500 patients. And then we also went to different areas in our community to provide vaccines to our patients. And at those vaccine events, we get to talk to our patients, about other things. One of the things that we were very proud of was that we actually hosted a virtual general patient meetings over Zoom. And we had over 250 patients that actually locked in. And we were able to do breakout sessions, in multiple languages. I can't remember, 7 or 8 or something like that. So I think these, and we also hosted like food distribution events, with other community health centers in the community. So I think just by doing that, we want to show to our patients that we are here, we are here for you. And, so come to us and ask us any questions, because that's what we are here for. So I think that definitely built a lot of trust and rapport to our patients, and the elderly patients just love coming to the food distribution events because they get to see other friends in the communities that maybe they haven't been able to see, during COVID, but now it's outdoor, so it's a little bit safer, and yeah. So that's what we did.
Wonderful. I think I'm going to combine the last two questions we have because I know that we have a good question in the chat, and I feel like looking at these questions that we developed ahead of time, I think that they fit together. So you all have talked about some of these elements that a health center might need already to provide culturally responsive care to Asian Americans as they age. So I'd love to hear just briefly from all of you around what else we might be missing in that we haven't covered, and who have been your essential partners in this work, especially to promote preventive services in this population. So, well, Dr. Lay, do you want to kind of answer that in a combined way, and then we'll go to the little folks?
Oh, sure. Yeah. I think, I mentioned earlier we have specialty mental health services. And in my last slide, I said we do more than just dentistry. And that's because, we do send flyers out to, we have our community service staff that actually goes out to the communities, and bring patients in. We established a trauma healing unit, for patients that experience, Asian hate incidents. But also, I just I want you to emphasize one thing, and is in our culturally competent care. Don't forget that we need to educate not just the patients, but the family members, the caregivers, and even the staff at the senior centers that we go to. They need to also understand how oral health is important to the overall health. And I think another thing that I want to say also is we also have to educate the male Asian patient population. They have the lowest utilization rate of oral health services. I don't know if it's fear-based, or I don't know if they feel like they're in denial. I don't know. They don't like pain. They don't want to find out what's wrong with them, maybe. I don't. But I think it's really education to the entire family unit, and not just those that come in. It's not uncommon that you may have just one or two family members that come in, and then the rest of the family members don't. But I think we need to involve the caregivers, the staff at senior centers, if we do go out to those centers. And as far as the county public health department, other API organizations in the area, I think that's important to involve them in this whole process, if we want to improve the healthcare outcomes of our patients.
Thank you for that. For Lowell, what other thoughts do you have in kind of wrapping up around essential partners? What else health centers might want to consider when they're trying to provide that responsive care to this group?
So something that we really focus on, and that has been really important, especially in terms of engaging patients for preventative healthcare, is our team of community health workers. So we have a number of community health workers who are Asian American, who are members of the groups that we serve in the health center. And we really have found utilizing those team members to explain why we're recommending the FIT test, the colonoscopy, why we're doing depression screening, why we're recommending screening A1Cs. We tend to get more engagement when it's explained by a member of the community. One of our main community health workers and interpreters from the Khmer community has been with the health center for many years. So she already has just a wonderful relationship with many of our patients, and she knows them from the community. And so working with her on encouraging like cervical cancer screening or colonoscopies, things that can be really scary, but that are important for preventative healthcare, and allowing her time in my visits to share her own experience with those preventative health services, I think has been really beneficial to engage my patients.
Yeah, that's fantastic. So just wanting to note that we have about 5 minutes left in the session. We'll get to the question and Q&A now, but if you have other questions that you're sitting with, feel free to put in the chat or the Q&A box. If we can't get to some questions today, or that pops up later for you, feel free to email us and we can pass things along to our wonderful panelists. But there was a question specifically around alcohol consumption, in acknowledging that it may impact health in various ways. Wanting to know what panelists think about talking about alcohol use, the stigma around that, addressing any concerns maybe that fall under kind of the substance use umbrella. Whoever wants to go first, yeah.
I'm happy to comment on this one. So in the Mesa Health Center and the larger Lowell Community Health Center, we do standardized screening for alcohol use disorder and drug use and tobacco use every year. So everyone is being asked these questions. And then if we have a positive screening, that's an opportunity for the provider to discuss more with the patient. I think what we find a lot of times is that alcohol in particular tends to be a substance that people choose when there are other things going on. So when they have untreated PTSD, untreated depression, issues with insomnia or anxiety. And so really working to encourage people to address many times mental health concerns as a way of working on their substance use disorder has been really effective for us.
Yeah, thank you, Sarah. Dr. Lay, what are your thoughts on that?
Yeah, so in our medical history form, we do have questions regarding drug use and also alcohol consumption. And of course, it's up to the patients to tell us honestly, whether or not they do, and we do have a way to ask additional questions just to get the patients to elaborate. But definitely during the pandemic, alcohol consumption has gone up. There's no doubt. And of course, domestic, violence, abuse. I mean, that we all know that, when everybody's so isolated. So anyway, so how we address that is that, because of the fact that we have 2 questions on our medical history form regarding that, and we spent time talking to the patient, addressing, those just one-on-one, very directly, just so that we could help our patients. And of course, it does happen with Asian patient population, males, a lot, just as smoking, and alcohol consumption. So so we just have to be very direct, with them. And of course, drug use, in the younger generation.
Yeah, thank you for that. I really appreciate all 3 of our panelists representing these 2 wonderful health centers for all of their insights and being able to get kind of a glimpse into your programming and the patients that you serve, and some promising practices, best practices that can really be applied across so many health centers that are working with Asian American elders. I don't know if Kara wants to share the rest of the slide deck. I'll say that there's lots of links. It's a great thing that you will be receiving a recording and the slide deck, because there's lots of further reading on this particular topic, as well as a great set of resources available in multiple languages that you may be able to use for your staff at your health center, your patients. So you'll be able to look through the deck when you receive it. Lots of great organizations working on accessible materials, and again, a variety of languages. And also, if you have resources that you are thinking of as we're going through this conversation and you want to share in the chat before we wrap up today, that's also wonderful. Again, so we thank our panelists so much. There's a quick link at some point in this deck around completing a quick needs assessment on training and technical assistance if you feel so inclined. That's part of our larger group of national training and technical assistance providers who are funded via HRSA for this work. But we also are going to ask you to fill out a very quick evaluation when you close out of the Zoom today. That's going to help us inform future sessions. And we'd love to hear what's on your mind after joining us for a session like this. So again, we thank everyone for their time today, our wonderful panelists, and for those who were able to join us live, thank you so much for your time and attention. We hope that you'll stay in touch, and certainly let us know if other questions or thoughts come to mind as you sit with the information today. So thank you so very much. Have a wonderful rest of your day. Take care.